Hello, I'm Dr. Michael Manka, attending physician and Associate Director of Emergency Medicine at the Erie County Medical Center in Buffalo, New York. Every day, many patients are seen by EMS and in emergency departments with injuries that can produce injury to the spine or spinal cord. The spinal cord is the nerve bundle that exits the base of the skull and travels within a canal formed by the spine. Peripheral nerves exit the spinal column through small foramen between the vertebrae that make up the spinal column. The spinal cord is thickest in the cervical spine, with very little space available in the canal. This lack of space in the cervical spinal canal means that the cord can be easily damaged by bony fragments or swelling secondary to injury to the spine. Spinal cord injury can be devastating. According to the Spinal Cord Injury Information Network, the lifetime cost for caring for a 25-year-old person with a spinal cord injury is estimated at between $1 million and $2.7 million in 2004 dollars. This varies with the level of injury. The life expectancy for a 20-year-old person with a spinal cord injury can drop to 36 years for a ventilator-dependent individual, compared with a life expectancy of 78 years for an uninjured 20-year-old person. Intubation of the trauma patient can prove challenging for even the most experienced healthcare provider. Due to the possibility of cervical spine injuries, it is imperative that spinal motion restriction be maintained during the trauma intubation procedure. Since additional training and experience are required for this procedure, it should be practiced regularly. In this module, we will discuss several techniques that can be used in both the hospital and pre-hospital setting for successfully performing intubation while limiting cervical spinal motion during the procedure. The trauma endotracheal intubation is indicated for patients requiring endotracheal intubation who have the potential for cervical spine injury. This may include multiple trauma patients, patients who are injured and obtunded, and patients with physical exam findings or complaints suggestive of a cervical spinal injury. In these patients, cervical spinal motion restriction must be performed to protect the spinal cord from damage during airway manipulation. While there are no contraindications to maintaining cervical spinal motion restriction in the patient with a potential cervical spine injury, the act of stabilizing the cervical spine limits the ability to optimally visualize the vocal cords. Depending upon the specific patient, spinal motion restriction may increase the difficulty in performing oral tracheal intubation. Providers must remember that without an adequate airway, the patient will suffer permanent disability or death, and the need to protect the cervical spine must be balanced against the need to provide a patent airway. In addition to standard intubation equipment, suction unit, BVM, and an oxygen source, the provider will need to ensure that a properly sized cervical collar and immobilization equipment are available. The addition of at least one, but preferably two assistants will also be necessary. These individuals should be familiar with maintaining cervical spinal motion restriction. Spinal motion restriction should be performed on all patients who have suspected cervical spine injury, are unconscious with a traumatic injury, or who have sustained multiple system trauma. During initial airway management, utilize the jaw thrust method of opening the airway and ensuring adequate ventilation. For a review of the jaw thrust maneuver, please refer to the head positioning and airway adjuncts module in this series. Cervical spinal motion restriction during oral tracheal intubation can be performed utilizing several techniques. The specific technique utilized is determined by the individual circumstances. In the pre-hospital setting, the patient is typically positioned supine on the ground. In this situation, the paramedic may decide to perform intubation while lying on his or her stomach. Alternatively, the paramedic may intubate from a seated position at the patient's head with the legs extended over the patient's shoulders and arms. Using this method, the paramedic can visualize the airway by placing the laryngoscope in the patient's mouth and then leaning back. In both of these cases, an assistant must maintain cervical spinal motion restriction. This can be accomplished by kneeling or lying at the patient's side and maintaining stabilization from the front. As a result of the variable environments that pre-hospital care providers must work in, continued training must utilize many different patient scenarios and positions, including in vehicles and other close space situations. In the emergency department, the provider stands at the head of the patient's bed during intubation. To maintain cervical spinal motion restriction, an assistant can either stand at the patient's side and hold stabilization from the front, or may kneel off to one side of the provider at the patient's head and maintain spinal motion restriction from the top. Many providers find that intubation is facilitated by loosening or removing the front of the cervical collar. This allows the provider to fully open the patient's mouth and can enhance the view. Opening of the cervical collar may also allow the assistant to maintain more solid contact with the patient and improve spinal motion restriction. The assistant may also help to improve visualization of the vocal cords by performing the jaw thrust maneuver while maintaining cervical spinal motion restriction. Laryngeal manipulation and cricoid pressure will also improve visualization and reduce the risk of aspiration associated with vomiting that may occur during intubation. After observing passage of the endotracheal tube through the vocal cords, confirm its position with auscultation and a secondary confirmation device. Secure the tube in place in the usual fashion. If the cervical collar has been loosened in order to maintain stabilization, it may be easier to secure the endotracheal tube prior to replacing the collar. In this case, the assistant should be instructed to maintain cervical spinal motion restriction until the tube is secured and the collar is replaced. As with any intubation, tube position should be reconfirmed every time the patient is moved. If the cervical collar was loosened for the procedure, reconfirm tube position after the cervical collar is replaced. Dislodgement of the endotracheal tube is a common problem in the pre-hospital environment. An unrecognized dislodgement of the endotracheal tube will produce catastrophic results and needs to be avoided. Providers should be aware that failure to provide inline cervical spinal motion restriction while intubating the trauma victim could result in a tragic outcome. Proper attention must be given to ensuring the spinal motion restriction is maintained throughout the intubation process. Cervical spinal motion restriction is a simple procedure that requires an assistant to hold the patient's head and cervical spine in a neutral position during orotracheal intubation. This is performed to prevent manipulation or movement of the cervical spine during the procedure. In traumatized patients, any movement of the spine during intubation may lead to tragic results. While it is important to prevent neurologic damage, cervical spinal motion restriction can produce difficulty in managing the airway, and the need to secure the airway must be balanced against the need to protect the spinal cord. By combining the use of inline cervical stabilization and intubation, successful airway management can be achieved while minimizing the risk of damage or compromising the integrity of the cervical spine.